Thank you. So good morning, everybody. It is a privilege and a pleasure to introduce Dr. Jason Nagata as our grand round speaker. Jason is no stranger to many of you since he was here as a resident, but let me tell you a little about where he was before and after that. His undergrad work was at the University of Pennsylvania, and then he did a master's in anthropology at Oxford University, and his MD degree at University of California, San Francisco. He then came here for pediatric residency and went back to UCSF for his adolescent medicine fellowship, where he also was in the AMSPDEC Pediatric Scientist Development Program as one of the very few clinical or health services researchers that has gone through that program, since it tends to favor our basic science colleagues much more heavily. Dr. Nagata is an associate professor of pediatrics and as of 2024 in residence at UCSF. I've been in California long enough to know what that means, so congratulations, Jason, on that. His research is really some of the only work that's been done and really groundbreaking work in eating disorders and muscle building behaviors in social media in boys and men. He has published an astounding number of articles, ranging upwards of 380, I think, by last count. And also, I actually have known Jason for quite a while now because he was the founding, one of the founding chairs for the International Association for Adolescent Health's Young Professionals Network. And so he's really been an organizer in the field as well. So let me not take any more of your time, but join me in welcoming Dr. Jason Nagata to today's Grand Rounds.
Well, thank you so much for that introduction and for the opportunity to talk today about eating disorders in boys and men, which is a, I think, understudied and under-recognized condition. But I also wanted to just thank you for being back at Stanford, and I hope to highlight throughout this talk also the really wonderful mentorship and sponsorship that I got at Stanford that really set my career trajectory for research over the next decade that really led to most of the work that I'll be talking about today. So as an overview of today's talk, I want to start with a clinical case, discuss some background and epidemiology, and then talk about specific symptoms of eating disorders in male populations, and then some clinical practical tools for how to assess, treat, understanding some of the unique medical complications in boys and men, and then finally talking about medical guidelines. So I wanted to start with a case. One of the first patients I took care of, actually as a medical student, was a 16-year-old male wrestler who was referred to our eating disorders clinic by his parents. They said that he was really obsessed with his appearance, weighing himself over 10 times a day, and he would really severely fast and restrict his food intake to make his weight cutoffs. And in addition to varsity wrestling practice for 2 hours a day, he also then went to the gym for all of his free time. So in total, he would be working out for 5 or more hours every single day. He tried to consume almost exclusively protein, mostly protein powders and shakes and egg whites, while trying to eliminate fats and carbohydrates from his diet. And he had actually been struggling for years with this before anybody thought that he might have an eating disorder. And when he was first evaluated in our clinic, he was bradycardic and needed to be hospitalized. And I remember as a young medical student trying to read as much as I could about eating disorders and guidance for boys with eating disorders. And at the time, there was very little available. And actually, back then in the DSM-4, amenorrhea or lack of periods was a requirement to be diagnosed with anorexia nervosa. And amenorrhea was also part of the medical guidelines for treatment. And obviously, none of that applied to this patient. So that really actually set the course of my research, first here at Stanford as a pediatrics intern, and then for the next 10 years to really better understand eating disorders in boys and men. And at the time, most body image and eating disorder research had focused exclusively on females, particularly with thinness and weight loss. But we know that the masculine body has become increasingly large and muscular. So to illustrate this point, I will cite the work of Harrison Pope, who examined trends in muscularity of male action figures actually over the last 30 years. So here we see Batman and Superman action figures from prior to 2000. And then now we see the current Batman and Superman figurines that our current children play with. And Pope actually did an analysis that found that over 30 years, there were statistically significant increases in muscularity in the biceps, triceps, shoulders, chests, and more defined abdominal and serratus muscles. And so even if you think about what our young, like 5, 8-year-old boys are playing with, this sort of is the backdrop of some of these body image concerns. Similarly, if we look at earlier Hollywood stars from past decades and sort of the male body image that they portray, compared to current Hollywood stars who appear to be bigger, bulkier, and have more defined musculature. So one particular area I think that has arisen in the last couple of decades has been social media. And so in 2021, Frances Haugen, also known as the Facebook whistleblower, released thousands of Facebook's internal documents to the Wall Street Journal and Securities Exchange Commission, leading to several high-profile testimonies in Congress. But I will say that a lot of the media coverage initially was really about how Facebook and Instagram had an impact on girls' body image. But what was really left out of the conversation was impact on boys. So I actually wrote that week an op-ed in the San Francisco Chronicle documenting all the ways that social media can also impact body image in boys. And so we actually know that boys are more likely to have public followings on social media than girls, and male selfies are more likely to have full body photos that show their musculature rather than just their faces. And a majority of male body image related Instagram posts depict muscularity and leanness. And so to achieve the idealized muscular body type, well, I guess one other thing that has been noted in research is that Instagram use in boys and men is associated with meal skipping, disordered eating, muscle dissatisfaction, and even use of anabolic steroids. So we worked with the Wall Street Journal, and subsequently they actually did do an investigation into body image and eating disorders and links with social media and boys and men, and that came out after the initial coverage on the girls. So just to highlight some of the ways that boys and men can achieve muscularity is, as was illustrated by the case, protein overconsumption while restricting carbohydrates and fats, use of appearance and performance enhancing drugs and substances like anabolic steroids or androstenedione or creatine, as well as compulsive exercise. So now I wanted to talk a little bit about the research that I've done on the epidemiology of muscle enhancing behaviors. And just to mention that a lot of the work that I did as a fellow here really was set up by leadership here like Becky Blankenberg and Mary Leonard and Hugh Brodovich at the time, who had nominated me for the Pediatric Scientist Development Program that John had mentioned, that really allowed me to get training in epidemiology and biostatistics to run all these national analyses. So the first one that I was going to talk about is we just looked at data from the Youth Risk Behavior Survey, which is a nationally representative sample of high school students, to really understand how common are these muscle building goals, how common are weight gain goals in the US high school population. And the Youth Risk Behavior Survey did ask about weight attempts. So if people are trying to gain weight, lose weight, or stay the same weight, what their perception of their own weight was, and also their weight and height, so you could calculate body mass index. And there had been a lot of focus previously on loss, like weight loss goals, so girls trying to lose weight, but people hadn't really analyzed the weight gain goals. So when we look at results stratified by sex, we find that actually by body mass index, only 3% of the male sample it would be considered underweight. But actually 19% of the males perceive themselves to be underweight. So there is a mismatch between their actual weight and their perceived weight, particularly in the boys. We also found that actually a third of boys were trying to gain weight compared to only 7% of girls, whereas in contrast, unfortunately, 61% of girls nationally report that they're trying to lose weight, and that's just in the general high school population, compared to only 31% of boys. So in the previous slide, we found that a third of boys are trying to gain weight among high school students. And this slide shows the proportion by current weight status as classified by BMI. So unsurprisingly, a large proportion of those who are considered underweight by BMI report that they're trying to gain weight. But I think one kind of interesting thing to note is that in the sort of normal weight group, let's see if, in the normal weight or overweight group, or even obese group, there are larger differences. So even 40% of boys who are considered objectively to be normal weight are still reporting that they're trying to gain weight and bulk up. And that's where we sort of see the big differences. So the Youth Risk Behavior Survey is a great repository of data, but it's just cross-sectional data. So we wanted to look at a longitudinal data that followed people over time. So we looked at the National Longitudinal Study of Adolescent to Adult Health, which followed 11 to 18-year-olds 1 year, 2 years, and then 7 years later, and it's an ongoing cohort study. It's also nationally representative. AdHealth actually asked about specific behaviors like weightlifting, exercise, supplements, dieting, performance-enhancing substances, and anabolic steroids, all with the goal of building muscle. And so we tried to see how common these behaviors were, again, in sort of a nationally representative adolescent population that's followed into young adulthood. So similar to the Youth Risk Behavior Survey findings, we did find that overall weight gain attempts, so the blue is the males and the red is the females, are quite common among adolescent and young adult males. And weight gain attempts sort of peak around ages 20 to 22, with over a third of young men reporting that they're trying to gain weight and bulk up. In order to achieve this, they're engaging in any type of muscle building behavior, which can range from weightlifting, exercise, and use of performance and appearance enhancing supplements. And again, this peaks around ages 20 to 22 in young adulthood. So when we look at the prevalence of specific behaviors, we do see that weightlifting and exercise are quite common. Nearly 20% are engaging that specifically for the goal of enhancing muscle, much higher in the males than in the females. Supplements and dieting to enhance muscle are also common. And even anabolic androgenic steroids, which technically are illegal, still about 2.8% of the male population has reported that they've used these, whereas legal performance enhancing substances, so that would be like creatine, is more common, so 15 to 20% of young men report that. Next, we wanted to look at predictors of muscle building behaviors in males. And so we did find that Black or African American race, body mass index Z-score, and participation in team sports all predicted muscle building behaviors in males. And one kind of area that I wanted to highlight was actually work with Gary Darmstadt in conjunction with the Lancet series on gender norms, where we actually looked at gender norms and their relationship to weight behaviors. And so here we can see that, let me see if I can find the clicker here. So here, this is like gender normativity score. So the higher the score, the more like masculine the sort of the male's gender norm is. And so here you can see that with weight loss behaviors, there's sort of a negative relationship. So the more masculine their norm is, the less likely they are to have weight loss behaviors. And but then conversely, with the more masculine score, they're more likely to have weight gain, to trying to gain weight, or also having a weight gain behavior. And these upper column or rows are for 1 year follow-up, and then the next rows are actually for 7-year follow-up. So these norms do persist into young adulthood. Another area that we noted was that adverse childhood experiences actually were a major predictor of future anabolic steroid use, and the odds ratios were actually quite high. So experiencing childhood sexual abuse was linked with like a 9 times higher odds of eventually using anabolic steroids in young adulthood. Physical abuse, 3 times greater odds, and childhood neglect also with higher odds. To a lesser extent, adverse childhood experiences also predicted future use of legal performance enhancing substances like the creatine. And some of the sort of theories behind trauma and performance enhancing substance use is that people may use performance enhancing substances to develop larger muscular bodies, to protect against additional trauma. There's a precarious manhood perspective where men may protect against threats to masculinity by exaggerating their strength. And this may also be seen as a coping strategy to prioritize short-term goals over long-term goals in physical and mental health. I also just wanted to give a shout out to Julia Rainey, who's here, who has been doing a lot of work on ACEs and actually has highlighted some of the protective factors of ACEs in these cohort studies. Thanks, Julia, for all of your work on that. And then finally, we looked at sort of longer term outcomes. So if people were using the legal performance enhancing substances like creatine, it actually was prospectively linked with future use of anabolic steroids. So in some ways, these legal muscle building products could actually be a gateway to illegal products. So people who use creatine in adolescence were actually more than 3 times more likely to use anabolic steroids by young adulthood. So I think one thing to note is that muscle building behaviors and goals are quite common. We've said that a third of teenage boys and young men are engaging in these behaviors. And that doesn't necessarily mean that all of them will have or develop an eating disorder. But they may be at higher risk for developing an eating disorder. And I think it's also really just important to recognize how common these body image pressures are for boys and men. I think the common narrative is, there's all these weight loss concerns in girls and women, and guys don't really care, but actually we do find that 2/3 of boys nationally are trying to do something about their weight. So they do actually care, and there are behaviors that are being acted upon. But I also think that we have data to show that engaging or using some of these performance enhancing supplements and drugs are linked with higher risk of eating disorders. And this study, I actually wanted to highlight one of my Stanford co-residents, Catherine Hill, who was on the faculty in adolescent medicine here previously, who actually was an NCAA swimmer here at Stanford. And she actually surveyed the top 10 NCAA swimming programs across the country, asking current athletes about their supplement use and eating disorder risk. And she did find that sports supplement use was associated with higher eating disorder symptoms, including shape concerns and restraint among these athletes. And so this just highlights that, particularly with the eating disorder examination questionnaire, there were higher risk, both in males and females, among those who used sports supplements. Next, I wanted to talk a little bit about symptoms presentations in males. In this, I wanted to just highlight actually some work that I worked on for Bonnie Halpern-Felscher's Encyclopedia of Child and Adolescent Health. We actually wrote an encyclopedia entry for eating disorders in males, and we provided some sort of distinct presentations based on the DSM criteria. And so I just wanted to highlight some of these here. So here on the left, you can see the official DSM-5 criteria for various diagnoses. So here's anorexia nervosa. And then on the right sort of column, we kind of highlighted some of the unique male presentations or considerations that you might consider when you're evaluating a male for these conditions. And so I think the first criteria in terms of weight, it's just important to note that BMI and weight may not be as low in males relative to females, especially given some of these concerns about muscle building. And so it's more likely that males may present with what they call atypical anorexia nervosa, which is they may still have all the symptoms, but their weight may be, or BMI may be in a normal range. And then in terms of the B criteria, a fear of gaining weight, the fear of gaining weight in boys and men may be related to obscuring one's muscularity, driven by a drive for leanness rather than necessarily thinness. And it can lead to use of performance and appearance enhancing drugs and substances. And then in terms of the disturbance in the way one views one's body weight or shape, the concerns may be more shape related, especially related to muscularity in males than weight. When we look at the criteria for bulimia nervosa, one of the sort of first criteria is binge eating episodes. And I think just one thing to note is that binge eating itself is a certain terminology that we medical providers use, but there is like a sort of conglomeration of overeating that some males, like in contemporary society, actually consider cheat meals, which actually have a lot of overlap with binge eating, but we just don't call it that. And so we sometimes are not, if we ask somebody, oh, are you binge eating, but we don't really describe it, or we are not really sort of up to date with the current lingo, we may really miss what's going on with people's eating behaviors. And then in terms of the compensatory behaviors, compensatory behaviors in males may not necessarily be using laxatives or diuretics or diet pills. It may actually be excessive exercise, or it may be using some of these performance or appearance enhancing drugs and substances. And then for binge eating disorder, the same sort of note that we had before, that binge eating may not be a term that guys relate to, but there may be other ways that they're overeating or having cheat meals that you could consider assessing for. And then finally, I wanted to mention that muscle dysmorphia is a diagnosis that's technically a form of body dysmorphic disorder. It's more colloquially known as bigorexia or reverse anorexia. And this is characterized by a preoccupation or obsession with insufficient muscularity, although in many cases, the individual's build is normal or muscular, and it can be associated with distress or impairment in functioning. And I think that this captures a little bit more of the muscle concerns that many men with body image concerns have. But I do think that there is also some confusion in that muscle dysmorphia technically isn't an eating disorder. And if you read the DSM very closely, actually they're mutually exclusive. So you can't have both muscle dysmorphia and an eating disorder, which I think can be confusing for providers and patients alike. In terms of assessment, I just wanted to note that actually, for the first time in 2022, the U.S. Preventive Services Task Force evaluated screening for eating disorders in primary care. And the recommendation based on a literature review actually was an I statement, so there was insufficient evidence. And part of the reason for insufficient evidence was that the screening tools had really primarily been developed in cisgender women, and they weren't really validated in male populations or people with diverse genders or diverse sexual orientations. And so, the measures for eating disorders have primarily been developed in cisgender women that reflect sort of the thinness and the weight loss, but maybe not the full presentation of eating disorders. And so I think that's just one thing to consider as we think about screening and some of the questions that we're asking in our primary care clinics. Aside from screening, like full-on assessment of eating disorders also have followed the same kind of patterns, such that most of the assessment tools were designed for cisgender women samples. And so some options are to use those initial tools, but maybe modify them to be more appropriate for males. Use the traditional measures, be aware of potential biases or incompleteness. And there are newer measures that have been developed or validated for both males and females, and then also to just use a combination. And so I just wanted to highlight here a few eating disorder symptom measures, like the Eating Disorder Examination Questionnaire or the Muscularity-Oriented Eating Test, as well as some body image-related measures that may capture more of the male experience. So in terms of assessing muscle dysmorphia in males, there is the Muscle Dysmorphic Disorder Inventory, which we actually have validated in male samples, as well as the Muscle Dysmorphia Inventory. And then in 2019, we actually did develop the Muscularity-Oriented Eating Test, which captures muscularity-oriented eating. So it's a 15-item measure that specifically looks at eating behaviors related to increasing muscularity. And there was evidence to support its reliability and validity in male populations. Other measures to consider are the Male Body Attitude Scale and the Muscle Dysmorphic Disorder Inventory, which have, as well as the Muscle Dysmorphia Inventory, which have all been validated in male populations. But I will say that they are kind of longer tools. They're not necessarily for screening in primary care, but more if you have more of a concern and want to do a more comprehensive assessment. Moving on to treatment, and first I'll talk about more mental health treatment. I think overall, it's just important to note that males are less likely to seek treatment, and there's already a stigma for people with eating disorders in terms of for regardless of their gender. But the sort of lived experience of many males that there's almost a double stigma, whereas there's a stigma for eating disorders, and because it's a feminized illness, there's even more barriers to trying to get care. That being said, just last year, for the first time was a evaluation of virtual family-based treatment that sort of looked at treatment outcomes by gender. So they looked at females, males, and also transgender youth, and found actually similar outcomes in all three groups with family-based treatment in a virtual platform with similar treatment outcomes in terms of weight gain, improvement of eating disorder symptoms, as well as improvement of anxiety and depression. So there is evidence for family-based treatment across genders now. Other things to sort of consider in terms of treating males is that there may be concerns about masculinity and particularly shames about symptoms related to eating disorder and a reluctance to focus on emotions. And oftentimes in the group therapy setting, it's just important to understand sort of what the demographics are. So I think a common experience, and perhaps this is even in the CCP here, is that if there's a group setting and you're like the only male in a large group, it can be even sort of more isolating. And so just try to consider that issues that many females may experience may not be the same that the males experience, especially in terms of body image goals and behaviors. And also being aware of just the genders and the sexes of the providers as well. So now I wanted to review some of the acute medical complications of eating disorders. And this is actually the research that really started my intern year here at Stanford. I remember very fondly my very first week of intern year when I was matched with Neville Golden as my advisor. And he was like, "Great, you're going to do eating disorder research." And all of a sudden I had all these projects. And I remember actually on my first week of night float, he had me like pulling things from the Cerner. I was pulling charts, and that sort of led to the first chart reviews that I will be talking about here. But that all happened in the night float halls of LPCH. But overall, we know that acute medical complications of eating disorders can affect all organ systems in the body. And most of the research has been on female samples, but there's a limited and growing body of research that's examined this in boys and men. And Neville also, as my mentor, invited me to sort of do a comprehensive literature review during residency on sex differences in the medical complications of eating disorders. And I'll highlight some of that here, going through each of the organ systems. So I guess, first of all, in terms of mortality, unfortunately, eating disorders are very serious and they are life-threatening. And studies that have looked at males specifically have found very high rates of mortality in male populations. So for anorexia nervosa, the mortality in males is about 13%. For bulimia, it's 11%. And so these are still very serious conditions that do require treatments and specialized care. In terms of medical clinical guidance, I do think that while we have great guidelines and guidance from professional societies, as I mentioned earlier, there are gaps specifically in the care of boys and men. And so one that I'll just note is that the Society for Adolescent Health and Medicine guidelines in terms of bone density and bone health currently say that given increased fracture risk, you should get a DEXA or dual energy X-ray absorptiometry when amenorrhea is present for 6 months or more. And obviously that is a guideline that doesn't apply to males with eating disorders. And so actually Lance Nelson, who was a fellow here recently, actually I helped to co-mentor with Jen Carlson, Bonnie Halper, and Felsher. He actually surveyed 100 adolescent medicine specialists who specialize in eating disorder care across the country. And because of sort of this lack of guideline, found that 54% of them were more confident assessing bone density in females, and 0 of them felt confident assessing bone density in males, perhaps because there's sort of lack of clear guidance. So one of the first projects I actually worked on while at Stanford was looking at that differences in bone density and body composition in males versus females with anorexia nervosa. And this is actually a collaboration with Mary Leonard and Jin Long, who's here. And despite the lack of guidelines as to when to get assessed for bone density in male eating disorders, we actually found that the bone deficits in males were equally severe in males compared to females at all the sites, so the whole body, lumbar spine, femoral neck, and total hip. So even though there's not current guidance as to when to get bone density assessments, it's important to note that the bone density is just as severe. We also had access to a UK database called the Health Improvement Network, or THIN, and conducted a retrospective cohort study looking at fracture risk. Because why do we care about bone density? Because people might be at greater risk of fractures. And we looked at anorexia nervosa compared to healthy controls without eating disorders, and then also looked at differences by sex. And so we did find that in both males and females, there was a greater fracture risk, but in males, that was most manifest when they were 40 years or older. So I think it's just important to note that sometimes, especially though we're dealing with adolescents, some of the, this sort of critical period during puberty to accrue bone, just like your growth spurt, happens in adolescence and young adulthood, but some of the effects may not be seen until later in life. So back to Lance Nelson's study, even though we don't currently have guidelines or guidance as to when to assess for bone density in males, he actually did assess among these 100 adolescent medicine eating disorder specialists. He asked actually, what do you consider, given the lack of guidance in terms of when to assess for bone density in males and females? And so this is a rank ordering of the considerations that sort of expert consensus has on when to get assessed for bone density. And so the top sort of most important factor in females was amenorrhea, so lack of periods. And then in males, the most important thing was fracture history, then degree of malnutrition, so how low their BMI or percent median BMI was, then duration of illness, then amount of weight loss, and then hormone labs. So you can see that while there is no official guidance, in general, people are looking at fracture history and degree of malnutrition to sort of help to decide when to assess for bone density. Moving on to cardiac or heart complications, at UCSF, we sort of did a retrospective chart review that found that overall of our outpatients, over half of adolescent males who were first evaluated in our for potential eating disorder actually met vital sign instability criteria, meeting hospitalization or medical hospitalization criteria at their first visit. And bradycardia was present in about 40% of males who presented. And I think it's also important to note that after they were hospitalized, among those with atypical anorexia nervosa, and again, that is more common in males than the typical anorexia nervosa, actually, males had lower heart rate naters than females. So the heart rate nadir in males was 40 beats per minute compared to about 45 or 46 in females. And 40% of males also had elevated total cholesterol. Looking at electrolyte abnormalities, these are also quite common in male populations. So about a quarter of males on initial evaluation had a low potassium or low phosphorus with lesser degrees of abnormal magnesium. One of the other things we assess for once somebody is hospitalized is for refeeding syndrome. And we actually found that among male patients, about 20% overall had some indication of an electrolyte change that could indicate refeeding syndrome, led with 12% of low magnesium or a drop in magnesium, 8% drop in potassium, and 4% drop in phosphorus. Blood complications or hematologic complications are also quite common. So we found that about a third of, in sort of outpatient settings, a third had abnormalities in hematocrit, 19% had abnormalities in platelet counts, and almost a quarter had abnormalities in white blood cell counts, including 10% with low absolute neutrophil counts. So it's just to say that the degree of malnutrition in males can significantly affect all of your bloodlines, and particularly even your white blood cells and neutrophils, which can make them relatively immunocompromised. Among inpatients, we also found relatively high rates of anemia and zinc deficiency. So interestingly, actually, even though we think about anemia as something that affects females more, among the eating disorder patients, we actually found that 50% of males who were hospitalized had anemia, compared to 24% of females. And zinc deficiency was also quite common. Looking at liver complications, this was also a project that I did with Neville and KT Park. We looked at the prevalence of elevated ALT at first admission for anorexia nervosa here at Stanford, and found that actually ALT, or that male sex or elevated ALT, was more common in males compared to females with anorexia nervosa. And there was some thought that actually other studies have actually done liver biopsies on people with eating disorders who have had really elevated LFTs and have found evidence of autophagy. So when your body is in a malnourished state, it can actually sort of harvest your liver for energy sources, and that can potentially lead to liver damage. GI consequences are also very common: bloating, nausea, and sort of slowing of the entire gastric lining. So gastric emptying of solids is delayed, and just progression through all of the GI tract can be slowed in males as well as females. One other, I think, interesting finding that we had in, I guess I will say that I started doing these analyses with the Stanford database, but as I moved to UCSF, we sort of started our UCSF medical registry, similarly set up based off of the Stanford one, and looked actually at all of our inpatients who had been hospitalized for about the last 10 years, and actually found that the males had higher energy requirements than females who were hospitalized. So by the time of discharge, on average, our males needed about 3,700 calories compared to 2,900 calories for females. But we kind of have them on the same protocol. They all start at 2,000 and they all advance by the same amount. So actually, on average, males at UCSF had 2-day longer hospital stays, and potentially because they have greater energy requirements, but we're kind of putting them on female protocols. In terms of endocrine complications, we know that malnutrition can suppress the hypothalamic pituitary gonadal axis. And so in females, we know that this can lead to amenorrhea. In males, 13% have had low testosterone levels, 9% have had low TSH levels, and 6% have abnormal 3T4 levels. So I do think that the same things can happen in males. We just don't have amenorrhea as that sort of clear physical marker without the labs. We also looked at vitamin D deficiency among hospitalized adolescents with anorexia nervosa or with eating disorders, and found that actually 44% of males had vitamin D insufficiency. And actually, in terms of severe deficiency, so vitamin D less than 12 nanograms per milliliter, actually severe deficiency was more common in males than it was in females. And then growth is another area. So linear growth suppression has been observed in a majority of males with anorexia nervosa. Sometimes this is actually the sticking point of patients who are in sort of disbelief. Male patients, like, height is very important to them. So if you tell them that they're not going to reach their full height potential, that often can be motivation to get them to sort of agree to treatment. So this study did show that there was evidence of growth suppression, and sometimes growth suppression actually preceded detection of the eating disorder. And it's just important to note that males could be at increased risk for interruption of growth because the growth spurt tends to occur later in puberty for males, and they, on average, grow for 2 years longer than females. In terms of neurologic complications, this is an older study, but one study of adolescent males with eating disorders found evidence of cortical atrophy on CT scans in 7 of 9 patients, kind of consistent with findings in females. So overall, in summary, even though there's limited data in males, we have started to show that sort of medical complications of eating disorders can affect all organ systems in males as well as females. And in some cases, the complications can actually be more severe in males. So I wanted to finally sort of summarize this by talking about guidelines. As I mentioned, that with that first patient when I was a medical student, I was trying to diligently read about how to take care of him, and there were no guidelines available. And so for the last 10 years, I've been trying to do epidemiology and clinical research to try to help inform these guidelines. And so a couple of years ago, we actually put together a book that sort of compiled best practices in terms of mental health, physical health, medical complications and many other factors in this book, Eating Disorders in Boys and Men. And then actually, as I mentioned, earlier iterations of the Society for Adolescent Health and Medicine guidelines really lacked specificity in terms of male populations. And it turns out that Neville Golden is the sort of lead author on these guidelines. And so when it came time to update them in 2022, he invited me to join the guideline committee. And I actually updated all the guidelines so that there are now male considerations in them for the first time. And that, again, was all possible due to sort of the mentorship and connections here at Stanford. So there's still a lot of work to be done, even though there is now acknowledgement of boys and men in the Society for Adolescent Medicine guidelines. They're still pretty limited. So I do think that there is always more that can be done. And I think that one final thing that I'll mention is mostly I've been talking about sex here, so like males and females. But I do think that one area of future work that I'm working on is actually looking at gender diversity, not just cisgender males, but also transgender and gender diverse. And actually that leads me to a collaboration with the PRIDE study, which actually started at UCSF, but now is based at Stanford. And so that is a national cohort of LGBTQ adults. And we've been working with them to try to validate all of these eating disorder tools for diverse genders and diverse sexual orientations. And so just very briefly for that work, sexual and gender minorities or LGBTQ individuals are at higher risk. Most studies have shown that they're at 2 to 4 greater risk than cisgender or heterosexual peers, potentially because of societal stigma, discrimination, bullying, internalized homophobia or transphobia, self-objectification, that could lead to body dissatisfaction, low self-esteem, and disordered eating. And so based on data from the PRIDE study, these are in adults, but we have seen actually quite high rates of eating disorders among gender minorities. So in transgender men, self-report was about 11% of having an eating disorder diagnosis. Among gender expansive or non-binary people, almost 14%, and among transgender women, 8%. And I think one interesting thing is that we looked at sort of these eating disorder symptoms based on, for transgender women, gender expansive people, and transgender men. And it does seem like the symptoms sort of track more with their gender identity than their sex assigned at birth. So if you think about the sort of traditional feminine gender norm that sort of values thinness, transgender women who would have been birth assigned male have the highest sort of eating disorder, traditional thinness related symptoms, whereas the opposite is true for muscle dysmorphia symptoms. So transgender men who would have been female assigned at birth have the highest muscle dysmorphia symptoms, and then kind of the reverse for transgender women. So I think the next sort of area that I'm really trying to work on is trying to make the guidelines also more inclusive for sexual and gender minorities as well. So with that, I just wanted to thank all the amazing mentors and collaborators that I've had here at Stanford. Here's a listing of some of them, but all of these people have kind of informed the research that I previously mentioned. And also just a shout out to my co-residents. This is our residency class graduation, and I know many of them are still here. You can see Hannah Bassett and Whitney Chadwick and Carmen Powell, and also Stanford mentors like Neville, John Klein, Mary Leonard, as well as the amazing support I got from the residency program, Becky, Carrie, and Debbie, who is my coach, as well as other collaborators from institutions all over the world. And as well as my lab team. And I just want to shout out that Christiana Helmer is in the back from our lab group. And so with that, and a number of funders. So with that, I'm happy to take any questions.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.